My name is Bill Lumry. I practice in Dallas. I'm in private practice. I have a clinical appointment at the medical school and do some research, particularly in this area. What we're going to talk about today is this disease state, talk about how it presents, how to sort of screen for it and work it up, and then talk about some therapies that are available. What's exciting about this disease, again, as I mentioned, it's an ultra-orphan disease, and only 5% of orphan diseases have treatment. This one has 7 currently approved treatments for it in the United States. That we can talk about how that happened. So anyway, these are my disclosures. I'm multiply conflicted. I have opportunity to work with a lot of the companies that are in this particular disease space, and I am on the board of the Hereditary Angioedema Association of the United States. So our objectives today are basically to describe the signs and symptoms of hereditary angioedema and differentiate that from the other kinds of angioedema that you may see more commonly in your practices. Talk a little bit about laboratory findings and diagnosis of the disease, and look at the various therapeutic options that are available to treat this. And then obviously, as we do with all of our patients, no matter what their chronic disease is to individualize a plan that will work best for them and their families. So I'm going to start this with just a video.
I remember I was at school and I was talking to one of my teachers about it, and I was like, I don't know what this is. And I just remember going out in the hallway and crying. That's when I realized, I was like, life is going to be different from here on out.
So what is the presentation of just angioedema in general? Angioedema is obviously swelling, usually an asymmetric swelling of a body part. It can come on immediately, as you've seen people maybe swell up after they get stung by a bee or get a penicillin shot or eat a peanut that they're sensitive to, or it can take hours to actually build to a peak and then finally go down. The distribution is usually asymmetric. We're not talking about bilateral leg edema that you might see in other conditions that you've been talking about during this conference. And angioedema is actually in the top 3 conditions that often result in a hospitalization. And you can see a sort of a sequence of a guy as he normally looks over here on the left, progressing as he's having a swelling attack, and it could be from hereditary angioedema or any type of angioedema to the point that his airway closes and he needs to be intubated to have airway support while the angioedema goes down. So what can swell? Your face can swell, and this is a picture of an older woman who, again, normal on the left, when she's having a swelling attack on the right. You can see involvement of her lips and her face and her neck in that picture. Your hands can swell, again, the one on the right side being the swollen one in this group. And in certain conditions, and hereditary angioedema is one of them, you can actually have bowel swelling. And you can see a little bit on this sort of KUB that there's a cutoff here. You can also see that the villi look like thumbprints. They're not little fine structures like they typically are in the bowel, but there's so much edema they look like somebody's put their thumb along the bowel wall. On the right side over there is actually a capsule camera picture of somebody who is having swelling in their terminal ileum, and you can see in this picture things are completely shut, edematous bowel wall. If you look at the time, it's 3:17 in the morning. This patient was treated with a drug that would stop the swelling, and you can see by 4:11 in the morning, the swelling is down, the bowel is open, and fluids are moving through it again. So what kinds of things can cause it? By far and away, the most common cause of angioedema is an allergic reaction. And that can be foods, it can be drugs, it can be venoms, it can be a bunch of stuff. Radiocontrast media can often cause people to swell, particularly the ionic form of that. We know aspirin and the nonsteroidal agents are commonly also implicated. Sometimes autoimmune disease can result in angioedema. The most common form of angioedema that presents to the emergency room these days is ACE inhibitor. About 40% of angioedema that presents in the hospital setting or an ER setting is associated with ACE inhibitor. We also sometimes don't know, so the idiopathic group, if you will, and that could be either histamine mediated or bradykinin mediated. And then the C1 inhibitor-associated diseases, both the hereditary types and the acquired types that we're going to talk about, and then a rather rare form of hereditary angioedema where the C1 inhibitor levels are normal. The difference in the types or causes on the left side and those on the right side is usually those types of angioedema are associated with urticaria. Usually you have hives or redness or itching along with the swelling. You can have isolated angioedema without urticaria with allergic reactions, but it's less common. So again, the most common type is associated with mast cell mediator release, usually histamine, but other mediators have been implicated, leukotriene C4, prostaglandin D2, heparin. All of these things are released or formed by mast cells when they're activated. And again, 90% of the time, mast cell or allergic angioedema is driven by these mediators and associated with hives and itching as well as the swelling. In contrast to that, bradykinin-mediated angioedema, which is the angioedema associated with some types of idiopathic forms and also hereditary forms, is not associated with urticaria. So one of the take-homes from this talk is if you're talking to somebody who comes in saying they're having intermittent swelling episodes, the first thing you should ask them is, do you have hives or itching with them? They may talk about burning in their hand or their face or numbness, but they typically don't have itching. They typically don't have hives associated with that. So that's kind of number one. Number two is the swelling that goes along with a bradykinin-mediated reaction compared to an allergic reaction is relatively slow. So an allergic reaction can happen in minutes after somebody is exposed to something they're allergic to. Swelling associated with bradykinin often will slowly build over a period of hours, up to maybe 24 hours before reaching its peak, as we saw in that series of pictures in that gentleman, and then it'll slowly go down over the next couple, 3 days. The third thing to remember about this group in your history taking is when you were treated for this, if this has happened before, what happened? What did they give you and what happened? I came in, I got an adrenaline shot, and everything stopped within 30 minutes and I went home. I got a slug of steroids, I got a steroid shot, they gave me Benadryl, they gave me Tagamet, and nothing happened. That differentiation where this type of angioedema mediation is responsive to those drugs that we treat allergic reactions for, epinephrine, steroids, and histamines. The bradykinin-mediated reactions are not. So those three pieces of history can put you down sort of the right path of whether you're going to look for an allergic cause or look for a cause that might be something as rare as hereditary angioedema. So this sort of contrasts those two reactions. So onset, minute to hours with mast cells, bradykinin sort of hours as opposed to minutes. Urticaria with mast cells, not with bradykinin. Itching with mast cell disease, not with bradykinin. You can't have pain and burning with the angioedema associated with bradykinin. And histamine, steroid, epinephrine response to the mast cell mediated, but not to the bradykinin mediated swelling. So this is people, again, back to my initial point, this is a rare disease. Well, so why should we even think about it? This is a study from a center in Italy that collects patients that have angioedema. And these were patients that had angioedema and not hives. So these are folks with swelling without wheals or urticaria. There's 776 patients represented in this study, and if you look at this, some of these they found the factor, some of them they should have found the factor before they were referred, ACE inhibitor induced, etc. But if you go down here, you can see that 25% of the patients out of these 700 had this rare disease, hereditary angioedema or acquired angioedema. So again, if you see somebody with swelling without hives, all of a sudden this rare disease doesn't seem so rare anymore. They did have a large percentage, 38% or almost 40%, that were idiopathic. Most of those were allergic, if you will, or histaminergic, but 40 of those actually had probably a bradykinin-mediated swelling problem. So that's, again, trying to make the point that this isn't that rare if you have a patient that just comes in and presents with swelling. So what is hereditary angioedema? Obviously, a hereditary disease. It's transmitted as an autosomal dominant condition, and patients with it don't either make enough of a protein called C1 inhibitor, or what they make doesn't work. It comes in two types. Type 1 is the most common, 85%. These people don't make enough C1 inhibitor. The protein can't fold up properly to get out of the cell. The other group, 15%, are type 2, make up protein, but the protein is dysfunctional. Again, the characteristics are swelling, usually in the deep dermis, usually localized, asymmetric, maybe mildly itchy or burning or painful, and it lasts for hours or days. And you can see in this picture of this lady, here she is in July 2008 as she looks normally. In September on the 1st, she woke up with swelling of her face. It progressed to the next day to the rest of her face and down into her neck. Continued, she was hospitalized because they were concerned about her airway. Even a week later, there's still puffiness in her face. And then finally, 12 days later, she's starting to look a little bit like she did when she was having no swelling at all. So not a quick onset, quick offset type of a condition. So when did we start sort of knowing or thinking about this? This is a paper that was written by Sir William Osler, sort of the father of internal medicine for our country. Back in 1880, I think this is 88, was when this was published. And he was an observer. Back then we didn't have CT scans and lab tests and all that kind of stuff, so medicine was basically an observational practice. And you can see how he describes this. The occurrence of local swelling in various parts of the body, and he describes where the swelling may occur, may be associated with swelling and gastrointestinal disturbance, including colic or nausea or vomiting. And there seemed to be a striking hereditary disposition in his particular cohort. He had 5 generations that he had tracked with this particular problem. As you know, with an autosomal dominant disease, basically 50% of the offspring have an opportunity to have the disease at each pregnancy. And this is a disease that actually presents. In other words, it's almost completely expressed. It's not, you don't have this problem and not have the swelling problem associated with it. So if you look at the title, he called it Hereditary Angio-Neurotic Edema. And the reason he did that is these families told him that things that would trigger the attacks would be stress and anxiety. He thought that this was actually a neurologic condition, and if you read his textbook that was published a year or so after this, he published his first textbook at age 38. This is an older picture of him, obviously. I'm still working on mine. I don't think I'm going to get finished. He put it in the chapter in the neurology chapter right after migraine headaches, which he also thought was a neurosis. Fortunately, we learned that this is a biochemical problem and not a neurotic problem, and we removed the neurotic from the title in 1982. Took 100 years to sort of just call it hereditary angioedema. So this is a picture of a family. And you can see the first one, the index case that was able to be found out of these 3 generations was up here. This couple had 4 kids, all of whom had hereditary angioedema. And you can see the mix is same for men and same for women, if you will. This is not an X-linked sort of disease. This couple only had 2 of their 4 kids to be affected. This couple only had 2, and in this group, nobody had disease, and in this group, 3 of the 4 had disease. So that's just a very brief review of what an autosomal dominant disease looks like, and as I mentioned, this is fully expressed. So we didn't know. We knew people swell. Again, Osler thought it was some craziness that was causing it. This lady, Virginia Donaldson, who was working in Cincinnati in the 60s, found that patients that had hereditary angioedema lacked C1 inhibitor protein. She didn't understand really why that would make you swell, but she was the first one to describe this. Shortly after that, some people working in Bethesda in the Army hospital there also described the absence of C1 inhibitor, and also another group of patients that had C1 inhibitor that was not functional. So finally, 1962, 60, 80 years after Osler had described this, we had maybe a mechanism for what was happening to these individuals. So how frequently does it occur? I've already sort of mentioned that, but probably somewhere around 1 in 50,000 individuals. There's no ethnic or gender differences. It's been described all over the world. The attack frequency in untreated patients is about 24 attacks a year. Before treatment, these attacks could last 2 to 5 days, which obviously is pretty disruptive with your life. The disease severity is highly variable. Some people may swell twice a year, and some people may swell every week. The types of swelling they have is also highly variable between patients, and even within a patient, it changes with time. There doesn't seem to be any relationship between how low or how high their C1 inhibitor level and how severely they're affected, which is kind of interesting. Conrad Bork, who has about 700 of these people in Germany, did a study looking at when this typically started, and you can see this is kind of a pediatric disease. The 50% or more patients present when they're kids, before the age of 10. Another 50% or 45% present by the time they're 20, with kind of a peak around puberty, particularly for women. But again, by the time somebody is 20, 25, they will have swelled if they've had this problem. That's important because if you see somebody out in their 4th or 5th or 6th decade that presents with this kind of presentation, swelling without hives, you've got to think about another disease that's associated with C1 inhibitor deficiency, and that's called acquired C1 inhibitor deficiency, usually associated with a lymphoreticular neoplasm of some sort or an autoimmune disease. So they go through the first half or more of their life, no swelling, they develop some type of a problem where they're either consuming C1 inhibitor or an antibody is chewing it up, and then they start swelling, and interestingly their lab looks exactly like type 1 HAE. So if it happens later, think about acquired. If it's happening earlier, then think about hereditary type 1 or type 2. We've already seen some pictures. I'd point out to you, this is what somebody's uvula and further down looks like during a swelling attack. You can see there's a very relatively small airway there. And the mode of death of these individuals is asphyxiation. We know that if somebody has a laryngeal attack, and fortunately they're the least common, but about 70 to 80% of patients will have a laryngeal attack sometime in their lifetime, that is fatal 40% of the time. And that's what these people live with, or used to live with, before there was treatment. Rare disease, you don't think about it, you don't diagnose it. That's one of the reasons we're doing these presentations around the country. And that's, if think about it, it's easy to screen for. If you don't, people go from doctor to doctor trying to figure out what's going on with them. You can see that even in recent times, modern times, the delay of diagnosis is sometimes more than 20 years, and that's the same whether it's here in the United States or around the world. Things have gotten better with Dr. Google. You can go into Google and put in hand swelling and stomach pain, and the first 2 pages is hereditary angioedema. We can sort of thank that finding to the Hereditary Angioedema Association, which is an advocacy organization that's put a lot of information out there, and frankly the pharmaceutical companies that are now providing drugs to treat these people. So if somebody comes in and says, I think I have hereditary angioedema, I'm swelling just like my mom did, believe them, do a screen and move forward. You might be a hero. So this is what, again, we've seen pictures.
If you were to slam your fingers in a car door, right, your fingers would swell up. Well, my fingers would swell up too. The only difference is the swelling wouldn't stop. The body doesn't have the mechanism to tell it to stop. So my fingers would swell, my hand, my forearm, all the way up to my shoulders. And that would happen for about 2 to 3 days, and they would eventually dissipate like nothing happened.
One time, I swelled both eyes.
Both eyes?
And good, I never swelled in my throat. Finally.
There's one particular instance that I can remember that her eyes were swollen. And it was one eye that was swollen, and it was moving over her face to the other eye. And that was tough. That was tough because I knew that she wouldn't be able to see out of both eyes. And it would only last about a day, but it would be a rough day for her not to see at all.
We think about angioedema affecting parts that we can see, but in this particular condition, and actually even in ACE inhibitor-induced angioedema, you can get swelling of the bowel wall, as we saw in that one picture earlier on, where the bowel actually blocks. And the patients present with essentially a surgical abdomen. They have a bowel obstruction, they're bloated, potentially they may be vomiting, they may be dehydrated, and because of the vomiting or diarrhea, their white counts up. And before, again, these kinds of radiology techniques, many of these patients had exploratory laparotomies with normal appendixes and normal gallbladders being taken out because that was the only thing that could explain this recurring episode of abdominal pain. So, and it's a very common, 93% of patients with this disorder have these abdominal attacks. It's a little bit less common than the peripheral attacks, but almost as common. Often they have intractable pain. They talk about laying on the bathroom floor, just curled up in a ball and waiting for the pain to go away. Again, it presents like an intestinal obstruction. Again, they may lose a lot of fluids and have the signs associated with that, including hemoconcentration. They may have a bloated abdomen and sort of a rebound response, which again used to get the surgeons very excited about this. And about 25% have had unnecessary surgery due to this.
I kind of just feel my stomach just kind of expands, like when you're bloated from eating food. That's kind of what it feels like, and then the pain kicks in, and your stomach gets more swollen.
So laryngeal edema, as I mentioned, is the most feared site of swelling. Happens in about 80% of patients with this disease. If you look at all the attacks, it only makes up about 0.5% of all the swelling attacks, but it only takes one. This is a series, again, from Conrad Bork, who went back several generations and looked at individuals. He found 70 people in those cohorts that had died with the laryngeal attacks, and you can see the age at which they died, often very, very young. He also described in that paper sort of the phases that people talk about when they are having a laryngeal attack, and phase one lasting, usually 2 or 3 hours with a feeling of scratchiness or some sort of a funny feeling in their throat, maybe not able to swallow secretions, maybe changes in the voice. The second phase lasting less than an hour, where you're starting to feel some stridor, some difficulty getting air, and then the final phase, which may last around 10 minutes, where your airway closes and you're not able to breathe any longer. We try to teach patients that to pay attention at this point and get some treatment rather than waiting until here when treatment has to be given very, very abruptly or the patient is going to pass away.
When I went to the bathroom, I went to swallow, and I couldn't swallow, and it was kind of like the weirdest feeling in my life. Like I was drowning in my own saliva, and now I can't breathe. I just accepted, this is it, I'm probably going to die this way. So I slid to the bedroom, and I went to pull on the blanket. Father woke up, and he's like, oh my God, what's wrong? And I was tired of trying to breathe. Like I just had nothing left in me. As soon as they got me to the hospital, they had to intubate me. So it took 12 days, and then I was in step down for 6 days. And it took like the whole summer for me to get my voice back.
So what causes this to happen? Some patients have triggers, but not all. Probably 40% can recognize their triggers of an attack, but 60% you just don't know what brought it on. Some of the things are listed here: physical trauma, as it applies to us as physicians or possibly dentists, doing things around people's mouths, intubating them, putting scopes down into their belly, again, dentists working with the teeth or gums. That kind of trauma is enough to cause a swelling attack and may well lead to airway obstruction if it's not managed properly. Infection, particularly when associated with fever, can trigger this. Emotional stress, we've already talked about that. And then maybe more importantly for us to know is that some of the medicines that we use can make this worse. Estrogens seem to make swelling episodes more severe and frequent. Interestingly, androgens make them better. Androgens actually induce hepatocytes to make C1 inhibitor and can actually raise the level to the point that the attacks don't occur. But oral contraceptives, hormone replacement therapy tends to make it worse. What do ACE inhibitors do? And the answer isn't they inhibit ACE. Well, but the answer is they inhibit ACE. So what happens when you inhibit? What happens when you block the metabolism of angiotensin converting enzyme? Angiotensin converting enzyme, which is primarily present in the lungs, is responsible for breaking down bradykinin. Okay? The way it works for blood pressure is that bradykinin is a vasodilator, right, circulating around, and if you block its metabolism, you essentially raise the body's bradykinin level, cause vasodilation, blood pressure goes down, and other good things happen in the kidney. Okay? So somebody whose disorder is they make too much bradykinin, and we haven't quite gotten there yet, we suggested that at the beginning, you don't want to give them an ACE inhibitor because they've already got too much in the first place. So that's a drug you don't want to use in these individuals. Okay, so probably should have shown this slide before that slide. So this is a picture of the contact system, not probably something we all saw in medical school for about 15 minutes and then moved on to other things. This is part of the coagulation pathway. So the coagulation pathway is over here. Factor 12, if you recall, is Hageman factor. Starts off the clotting cascade going down this side. The contact system is kind of in the middle, and then the complement system is down here on this side. Okay? C1 inhibitor actually acts in all three systems, the coagulation pathway with plasmin and plasminogen, in the contact system, and also in the complement system. The dots are where it acts in regulation of this contact system, and you can see it starts up here at the top. When you activate factor 12 by trauma or something else, then factor 12A or activated factor 12 is produced. Activated factor 12 breaks kallikrein into another chemical or protease called kallikrein. Kallikrein acts on high molecular weight kininogen, and that produces bradykinin. If you don't have regulatory, then that just goes immediately to that point, and actually there's a feedback loop from kallikrein back up here that's shown right here that gets this thing going crazy. I'm going to tell you in a minute that the best screening test for this HAE is to do a C4 level. But you can see this really doesn't have anything to do with the production of bradykinin. C1 inhibitor, and that's how it got its name, inactivates activated C1. If you activate C1 and don't stop it, it breaks down C4 and C2, so the C4 levels go down. And then the rest of the complement pathway can go forward from there if it's on a surface. So C4 has nothing to do with the swelling, but it's a good screening test for this disease because this goes down if you lack functional C1 inhibitor. If you look at this, you can see where you might, thought I could go back, but I don't think I can. Let's see. It went back too far.
When I went to the bathroom.
Okay, you can see where you might block this up. So you might do something like give people that have a deficiency the C1 inhibitor back, right? Makes sense, you're just replacing what's missing. You might do something, since this is a key protease in this pathway, you might do something to inhibit its action so that you don't make bradykinin. You might do something to prevent bradykinin from interacting with the blood vessel, which causes the leaking and the swelling to occur. Okay? Other places you might act, you might be able to shut down factor 12A, possibly. Maybe you could not make kallikrein by blocking prekallikrein. Turns out all those things are possible. And the current therapies we have, which we're going to talk about, are replacing C1 inhibitor to either prevent attacks or treat attacks, blocking kallikrein to either prevent or treat attacks, and then blocking the bradykinin receptor to stop acute attacks. So we've hit this pathway. It's a fairly simple one. That's probably why we had 7 drugs to treat this disease in all the places that you might want to do that. So those are approved. This drug to knock down prekallikrein is in clinical trials. The drug to block factor 12A is in clinical trials. So we're hitting about everything that we can hit. What happens when bradykinin attaches to the blood vessel endothelial cell? It attaches to the B2 receptor, and that causes vasodilation and then increased vascular permeability and angioedema. So we've already talked about the types of C1 of type 1, type 2, and HAE normal. I'm going to show you another slide because this is better, of the laboratory that you might see in these individuals. So these are complement tests: C1 inhibitor function, C1 inhibitor level, the C4 level that we talked about, the C3 level, which is downstream from the activation or degradation of C4, and then the C1q level, which is part of the activation of C1. So in type 1, they don't have enough C1 inhibitor, and therefore they don't have enough functional C1 inhibitor, and the C4 level is low. These things are not affected. In type 2, they have plenty of C1 inhibitor, maybe more, but it doesn't work, so the function is low. But because the function is low, their C4 level is low. That's still being activated and degrading. In HAE with normal C1 inhibitor, as the term suggests, everything is normal. In that disease that I told you about in older individuals that present with swelling without hives, acquired C1 inhibitor, they are using up all their C1 inhibitor, so they don't have enough to be functional, and the C4 level is low. The difference is they often will have 70% of the time they'll have a C1q level. So that's a bit of a differentiation between this type and type 1. In ACE inhibitor, it's all normal. In idiopathic or histaminergic, it's all normal. So you can see here one of the tests that would be helpful in screening out these diseases would be a C4 level. Yes, sir.
With regard to that ACE-associated angioedema, I'm trying to figure this out in my head. The hospitalized people we give fresh frozen plasma to, if everything's normal, what exactly are we doing?
Probably nothing with C1 inhibitor. Fresh frozen plasma has 1 unit of C1 inhibitor per cc of plasma. So you're giving, if you give them a couple units of C1 of FFP, they're getting 1,000 units of C1 inhibitor. Probably doesn't help. Another, if you think about this, if the problem is an ACE inhibitor producing too much bradykinin, then the drug that you want to do or use is one that blocks the effect of bradykinin on the blood vessels. There have been some studies with that. There's 2 drugs that do that, and one of them, which is called icatibant, is probably something that would be useful for that type of swelling. But the study that was done to look at that failed primarily because of the study design. The way they set their endpoint, it didn't show to be effective. But if you have icatibant in your emergency room, and the pharmacist will let you have it, it works right here to block the receptor, so bradykinin can't interact and cause swelling. So and you need to realize that all of these treatments for acute attacks they stop the swelling. They don't make it go away right away. The swelling has to be picked up by the lymphatic system, but patients feel better actually quite a bit quicker than you'd think they would, particularly with abdominal attacks and throat attacks. So we've sort of gone through that. Okay, so how to diagnose this particular rare disease? Well, first of all, episodes of angioedema without urticaria, I pounded that home. may have associated abdominal pain. And in fact, that's how they may present to you. They may say, I keep having these weird episodes of belly pain, I throw up, my stomach swells up, I go to the hospital, they can't find anything wrong with me. They've done an abdominal CT, you might see some swollen bowel wall, you might see some ascites, but usually they don't find, or a dilated loops of bowel if there's an obstruction, but they don't find anything. You might ask them, well, does anything else swell up? Oh yeah, my face swells up, my hand swells up, but that's not really why I'm here. I'm here for my belly pain, because that really takes me out of the game. Well, think about this disease. Maybe they've had an episode of laryngeal edema. Do they have a family history of HAE? 75% of the time they do. 25% of the time the mutation is spontaneous. So if they have any of this stuff, then get a C4 level as a screening test. It's going to be low even if the patient's not swelling about 95% of the time. If you still suspect the disease and the C4 level is normal or low normal, then get it during an attack. Get the ER doc to draw it during an attack. Or you can move forward and measure C1 inhibitor protein and C1 inhibitor functional levels, which aren't affected by the attack. They're going to be low all the time. So if they have low C1 protein, they're type 1. If they have low function, then they're type 2. If normal for both, then think about other causes of angioedema, thinking about that pathway, histaminergic versus bradykinin. So who do you screen? This top piece talks about using some plasma products, and before you use them, for the long term, you might want to screen for other diseases that might be present. But with patients with HAE, individuals who know their family has been diagnosed, once you've got an index case, it's a good idea to really screen everybody in the family. These tests are good from 1 year up. Below 1 year, the complement levels aren't particularly stable. So if you're going to screen a baby, if somebody you know has HAE, wait for them to be a year old and then grab this lab on them. You don't want to go to the emergency room with HAE not knowing that you have HAE, because they're going to treat you. Think about it. When somebody comes in the ER, you're going to get epi, you're going to get steroids, you're going to get all that kind of stuff, and it's not going to be useful. If you can come in with a diagnosis telling somebody, hey, I've got HAE, here's my identity card, here's my treatment plan, let's get going. FFP may be the treatment then if there's nothing else available, because you can provide C1 inhibitor and stop the attack. Okay, so there's sort of two ways to think about therapy. One is everybody needs to be able to treat their attack when it occurs. Okay? And in the old days, meaning 10 years ago, that's what we did. We were just trying to keep people alive. Nowadays, we have a way to actually prevent attacks, and I think we're sort of swinging that pendulum to prevention away from just treating the attacks when they occur. When you think about it, all the diseases we treat that way, except maybe infectious diseases. If somebody's got high blood pressure or other things, we don't wait till they have their heart attack or their stroke to start treating it, right? Same thing with diabetes. We try to keep the blood sugars in control before they develop kidney disease or they have diabetic ketoacidosis. In this disease, we've been treating the heart attacks, we've been treating the diabetic ketoacidosis and not worrying about prevention. But we have therapy now that can do that. So these are some of the places we've sort of looked at targeting. We can target kininogen or plasma kallikrein, we can target bradykinin as well. So here are the therapies that we have available. I said that there were 7 approved. So for acute therapy, we give back C1 inhibitor. This is a human plasma-derived one, bare inert. This is a recombinant C1 inhibitor that works just as well, made from an animal, so you don't have to worry about plasma supply or infections that might be transmitted in the plasma. So that's sort of been the therapy since the 70s in Europe and since 2009 in the United States. We can block that bradykinin receptor that we talked about with icatibant. We can block the plasma kallikrein activity with a drug called encalantide. So we can hit the pathway in a variety of ways to actually stop attacks. What do we got to prevent attacks? We can use C1 inhibitor infusions. It has a half-life of about 40 hours, so you've got to do it every 3 to 4 days to keep the levels up. You can do it by IV, or you can do it by sub-Q. This prevents about 50% of the attacks. This prevents about 95% of attacks. You can also block the plasma kallikrein activity with a monoclonal antibody called lanadelumab or Takhzyro that shuts down the production of bradykinin without having to worry about what the C1 inhibitor levels are.
slide, the preventive versus the acute. Is
Sure.
it just the same medicine? Or are they
Yep,
formulated?
yep. This is plasma derived. It's just made by a different company than this one is. This is just concentrated that.
So it's all the same stuff.
Yeah, this is all human plasma derived C1 inhibitor. This is a recombinant C1 inhibitor, and then these are different chemicals down here. So these are sort of this laid out in a table looking at side effects and disadvantages and advantages. The C1 inhibitor replacement, the advantages are you're replacing what's missing, if you will. The problem is with the intravenous drug, you got to have an IV every 3 to 4 days. With the subcutaneous infusion, all of these cost a lot, so that's really not fair. But the subcutaneous infusion also has to be done every 3 to 4 days. There are some potential side effects of all plasma drugs, pathogen transmission, possibly thrombosis. With the monoclonal, you can get some local injection site reactions, headache, rash. It's a subcutaneous injection every 2 to 4 weeks. Currently, we don't know about how it might work in pregnancy. We do know that the C1 inhibitor products have been around since the 70s. Many pregnant women have been treated with that, so if we have to pick a preventive drug for a pregnant woman, we would use a C1 inhibitor product. Before 2008, before any of this stuff was available in the United States, we used attenuated androgens. As I mentioned earlier, that raises the C1 inhibitor level, and it works. But you gain weight, your liver can fall apart, you get hyperlipidemia, you flip your LDL-HDL ratio, you might get cancer. If you're a woman, you're starting to grow hair. And so there's a lot of side effects associated with the androgens, although they are cheap and they're oral, but not really used anymore in the United States as primary therapy. You obviously wouldn't want to use it in a pregnant woman or a young child. So what about management guidelines? There's a whole bunch of them. These are just some of them. We've produced our own consensus document. It's going to be updated this year from the HAE organization, the Medical Advisory Board. There was a WAO guideline published in 2018. So it's all really up to date, much more so than our asthma guidelines. These are consensus documents. We've got good studies for some of the drugs, but some of it is just high quality consensus or not so high quality consensus data. We do agree that everybody should have an on-demand treatment. So once a patient has a diagnosis, they should have something to treat the attacks when they occur. Should be reliably and efficiently accessible, whether it's at the hospital or the patient self-administers. And it includes patients that are on long-term therapy. You want to have your nitroglycerin handy if you get chest pain, even though you're using a beta blocker or whatever. We all agree that nearly all attacks are eligible for treatment because they move. You might have a little finger swell and then it moves to your belly or to your face. So people will often treat and shut down the system early in an attack sequence. Obviously, laryngeal attacks are uniquely life-threatening, and patients are encouraged to go to the hospital immediately if they recognize that, even if they self-treat at home. We know that earlier treatment is better than later treatment. Again, less fluid is out there, so less swelling, less morbidity, and then we should think about prophylactic therapy depending on what the patient's situation is. So what about prevention? Again, everybody should probably have this, but these drugs are expensive, and some people don't feel like that they can afford them, or feel like they want to use them all the time if they are only having an attack every 3 months. So things that you think about are how frequently are you swelling? What kind of attacks do you have? How quickly does it come on? What kind of impairment do you have? What impact does it have on you for worrying about having when the next attack is going to occur? You need to have available an acute treatment plan and talk to the patients about the impact of the disease on their work and school. We'd like to make these folks normal, and actually we have drugs that can do that these days. So these are kind of the individualization of therapy piece. How frequently are you swelling? How quickly does it go? Has your throat been involved? And then we look at medications on how well they work, how safe they are, what's the patient's preference. It's a shared decision. What's the administration route, sub-Q, IV, oral? What's the source of the medication, and then what's the cost? So the health the plan, basically, everybody should have acute treatment, routine prophylaxis for some patients, and that's trending to be about 60% of patients now. And we try to get everybody involved with an HAE specialist at least for a consultation to sort of work all this stuff out. There's about 10 centers around the country that have large numbers of HAE patients, and we're happy to see patients with this disorder just in a consultation or on the telephone if need be with them. So this is sort of a comprehensive treatment plan. I'm not going to go through all the details that's in your deal, but obviously thinking about a diagnosis, optimization of the management, and maybe because a lot of these people live out in the sticks, being able to actually see them using a telemedicine format rather than having them drive 3 or 4 hours to come to your office. Again, there are centers around the country that specialize in this. Ours in Dallas is one of them. We follow about 110 of these individuals with type 1, type 2. There's an action plan that you can get from the Hereditary Angioedema Association. This one actually came from Australia, Dr. Catalaris down there. But basically, it's just like an asthma action plan or other action plans that you might use in more common diseases. We provide patients a letter. We give them an ID bracelet or a card. Sometimes we put their history on a USB drive. So when they do present to the emergency room, they can be identified with this disease and be treated properly. If somebody is going to a particular hospital or medical center, flagging their medical record just like you would for a drug allergy, where it pops up that they have hereditary angioedema, is also helpful in getting them through the triage process. Side effects, obviously, we monitor those for the drugs that we're using. Talking to the patient each time we see them about what their response to the therapies are, and are they having any side effects associated with it, either the administration side effects or other things that we've talked about. So special populations, what about kids? Big hole there. There's only one therapy approved down to age 0, and that's the C1 inhibitor IV from Bernard. We don't have any sub-Q therapy for them yet. The lowest one is age 12. We try to teach kids and women when they are moving into puberty to stay away from oral contraceptives that contain estrogens. They can use progesterone-only oral contraceptives, which actually may make the disease better. And then obviously everybody around the child needs to be aware of the disease that they have and be educated about it. Pregnant women, it's kind of a 30-30-30. They have all kinds of hormone swings, as you know, so you'd think they get worse, but it turns out 30% get better, 30% stay the same, and 30% get worse. It's different for every pregnancy with every woman. So we try to manage them, especially to make sure that they're being cared for properly around delivery. Interestingly, they typically don't swell, but you want to have something available in the delivery suite to treat them should they have a need to be intubated or have a swelling attack. So in summary, key to diagnosis is thinking about it. If you don't think about it, you won't diagnose it. There are plenty of patients in Indiana with this drug, with this disease. Most of them taken care of by a family practice office, again, down near Louisville. The diagnosis requires a laboratory confirmation, so if you get a low C4 level, then you may want to do the other tests to see what type they have. Obviously, within a family, they're all going to have the same type because they'll all have the same mutation. HAE patients should have an effective plan in place to treat attacks when they occur, whether they're on prophylaxis or not. And then some patients may benefit from prophylaxis, and I mentioned about 60% of patients now are being treated that way rather than just on acute therapy. We're hoping to get an oral prophylactic agent, but for the time being, the ones that we do have can be self-administered by the patient, so it keeps them out of sort of healthcare utilization and allows them to have a little bit more control over their life.